Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Did you know that Tempe, Arizona has foxes, desert foxes? Did you know that? I was at work last night and I saw a fox. I know what a coyote looks like. I know what coyotes look like. I know what wild dogs look like. I have these wild dogs right here. But there was a fox. I went back to work because I forgot something. It was like 9 o'clock at night, right? And I went in there. Got something. I walked back out, and while I'm walking to my car, I see a fox. It was the coolest thing I ever saw. Coolest thing. Never seen a fox in my life. So, a little fun fact for you. Let's get into the material. We're in the process of discussing menopause. This is the second episode, and this is one where I'm going to get a little bit more into how we diagnose it, because that's important. This is going to get controversial. So before we get in there, buckle up. But before we get into it, please subscribe. If you're on YouTube, which is our primary platform, you'll just kind of scroll down there and hit the subscribe button. And then wherever you are, just wherever you have subscribe. And if you like what we do, press like. And if you think it's going to help someone in their lives, share it. So let's get into this menopause. And why is it controversial, Brendan? Why is it controversial to diagnose it? I didn't realize it would be as controversial until I think a year and a half ago. I was posting some videos about menopause and diagnosing and understanding menopause. And there was such a storm around it, these posts. And the reason why is because I advocated for testing, for labs. And these people are like, you don't need labs. It's like, well, you do need labs. So my goal with this episode is to explain the diagnosis and why it's important we run labs, why it's important to understand the woman in front of us. More data is better data. It is so important. It is so important that as care providers, we provide care. And part of that care is really understanding the woman in front of us. You deserve 100% of this clinical mind every time. Every time. And if the doctor doesn't fully understand what's going on with you, you deserve that doctor to engage all of this to understand you. Always. Always. That's my treatment philosophy. That's who I am as a doctor. That's who I'll always be. So let's discuss this. I want to start off by saying, this is this is a journal article I used for this kind of fun. It's titled Reproductive Hormones and the Menopause Transition. It was published by Obstetrics Gynecological Clinics of North America. They said, the general opinion is that laboratory studies can support the diagnosis of PMS and menopause, but they're seldom useful and they're not typically ordered. And the thing is, they say they're not useful and they're seldom ordered. It depends on how you view menopause. It depends on how you view the woman in front of you. It depends on how you're going to treat them. If I'm going to be like a ghetto, fabulous, just low-grade doc coming into clinic, and I'm going to just, based on symptoms, run no labs, but just based on symptoms, just give you base treatments. If you come into clinic and you're telling me you have hot flashes and you're 40-something, late 40s, write you estrogen. That happens without lab work. That happens. Not to say that you could be having hot flashes because your thyroid's not right, or your hot flashes because your cortisol levels are off. Valid. Those things happen. The thing is, if your doctor just does this paint by numbers, here's your symptom, here's your drug. How are they any different than the kid at the health food store when you go in there and say, you don't have this, and they give you the supplement of the day? Being a doctor means you understand the person in front of you. Not that, I know what's good for this symptom is this. It's instead, you have these symptoms. These are the processes that may be going on in the person's body. Let me verify. Let me understand where you are, and then let me treat based upon what those lab values are. That's key. That's why we're doing it. The thing about menopause that everyone misses, but it's right there in daylight, broad daylight. It's right in front of us. Menopause is not a single moment in time. This is where we have problems with these doctors out here, is they just see it as a cut and dry moment. It's not. Menopause is a spectrum. You exist. We all exist on a spectrum. And as we move through life, we transition through things. But it's no hard one point. It's this, and the next point it's that. Very few times in life that it's like that. menopause actually begins in your early 30s. Sadly, people get always upset when they hear that, but it shouldn't be sadly because it's just life. When you're in so let's go back. Let's talk about what a cycle is because that'll help us understand menopause a little bit more and why we run labs. Okay. The beginning of a cycle, you just menstruate. There's going to be a lack of all hormones. Your progesterone, your sex hormones are going to be very low. When your pituitary recognizes not many hormones, it's going to send a signal down to the ovaries to recruit some eggs. The idea is going to have one being dominant, maybe two, and then several others that are going to generate follicles that will be supportive. Okay, so that's your first 2 weeks of your cycles. These follicles are going to be stimulated and brought to the surface here, and they're going to be growing, and then those follicles will be releasing estrogen. The estrogen that comes from those follicles are going to go to your tissues, go to your breasts, your uterus, your cervix, your ovaries, your body fat, your bone, your brain, all over. And what that estrogen is doing is going to be ideally getting you ready to be pregnant, but other things too that define you as a woman that are very important. The estrogen will also go to the follicle itself. So the follicle is releasing estrogen. Estrogen goes and saying, I'll go back to the follicle. So it goes to the follicle, and it's like almost a feed-forward pathway to stimulate the follicle with estrogen to become even more estrogenic. So the follicle is becoming increasingly estrogenic over the first 2 weeks, and then that increasing levels of estrogen hit a crescendo. And then crescendo around day 12, ideally. We're all different, but day 12 ideally. And when it hits that high level, the brain sees that high level of estrogen, says, all right, that's it, we peaked. Now it's time to ovulate. And then you'll send a surge of luteinizing hormone from the pituitary. It goes down to the ovaries and says, okay, these follicles, we need to convert them into corpus luteum. The corpus luteum secretes progesterone. And you also release an egg, or maybe two, and the hopes you're going to get pregnant. And I know every cycle you don't get pregnant, but this is how the body operates. It's what we have. So the corpus luteum now is going to secrete progesterone. You still have some estrogen, but progesterone is going to be dominant. Progesterone comes up. Progesterone goes back to all that tissue that is stimulated by the estrogen, and it's going to calm it down. So like breast tissue, it's going to lobulize that tissue. The lining of the uterus, it's going to stop the growth of the lining of the uterus. It's going to mature the tissue. It's going to improve blood flow to the area. All the tissue that's being stimulated by estrogen, progesterone is going to have a role in calming it down and regulating it for the idea you're about to get pregnant. And if you don't get pregnant, around day 28, again, we're all a little bit different. If you didn't get pregnant, there's no signal to come back to the pituitary. Everything drops down, and you drop all your estrogen and all your progesterone goes all the way down. You shed the lining of the uterus, and you start over again. That's a cycle, okay? When you hit 34, somewhere in there, it's different. And stress plays a huge role in this. I've done episodes on how stress impacts this. They're out there. But right now, let's focus on premenopause. When you turn 34, something starts to occur. You don't ovulate the same way anymore. You'll have a diminished return on the progesterone. The luteal phase, the second half of your cycle, where the corpus luteum, as I mentioned a moment ago, is going to be less. You have diminished progesterone from that. This is why women in their 30s, mid to late 30s, start to notice more symptoms of PMS. PMS by nature is low progesterone. That's it. So this premenopause state that occurs in the mid-30s, you see this is also, they consider it being diminished fertility. That is true because you're not ovulating as much. You're not having as much progesterone, more difficult to conceive. But this is the early stages of menopause. Progesterone starts to diminish over time. Symptoms of that are commonly depression, anxiety, insomnia, breast pain, heavy periods. And it's on a continuum, okay? So it's not as bad at 34. It just gets more progressively as you move forward. Most women get confused at this point. Most doctors get confused, They confuse the woman in front of them. And they don't quite know that's what's happening. So how many women in that age population are being given SSRIs? How many women in that age population are being treated for anxiety? This is more associated with the hormone. And this is the premenopause window. So progesterone starts to become down and become less. Sometime in your mid-40s to late 40s, again, your whole biology is completely different. You're going to have the next phase. So as you're moving from a normal cycling before your 30s and your 20s, great. Normal should be balanced with estrogen, progesterone, ideally. You start to have diminished return. You have less and less progesterone. You're starting to get this estrogen dominance happening in the background and all the symptoms that go with that, as I mentioned a moment ago. The next phase is you're going to have, it doesn't happen every time, but it happens often enough. We have these surges of estrogen. You're going to have these hyperestrogen cycles. I've seen them. It's crazy. Ideally in this window in your 40s, your estrogen should be your luteal phase estrogen, which is day 21 of your cycle around. Your estrogen should be like 120, maybe 200. 200 is pretty high. I'll see like 800, 900. It's like, what happened? You'll have these surges of estrogen. It just happens. It's a part of practicing medicine. You run labs often enough, you'll see it. These are when women have these emotional, I will never be a woman. I will never, ever know what you go through. I'll never experience that. With that said, that doesn't mean I can't have empathy for you. When you hit your estrogen at 900, it is unfair because it robs you of your own agency. You no longer feel like you're in control of your own emotions. And you had no idea it was coming. It is traumatic and uncomfortable. I mean, just the emotional component alone. Then you have the physical component. The breast pain for many of you, the heavy periods. Weight gain, no libido, pain with intimacy. This is another phase of menopause. This happens. It really does. Then you have the next phase of menopause is that's when the ovaries are completely diminished and you're going to have no estrogen. There's a window of time where it just happens. It just kind of sputters and then it's gone. And then you're down to no estrogen. And that's when you have those symptoms of hot flashes, night sweats, vaginal dryness, urinary tract infections, the most common ones. And also the emotional component as well. Because estrogen is funny. It's not good when it's too high. It's not good when it's too low for your brain chemistry and your mood. So menopause has these windows in these times. Why is it controversial to run labs, Brendan? Why is it controversial to run labs? Because people believe all menopause is that final stage of it. And all you do is give them estrogen. Fine. If that's how you're going to practice medicine, fine. The question I have for you is if you don't run lab work, how do you know where they're in that final stage? And they're not somewhere near that one where they're having these hypersurges of estrogen. And I say that because in practice, I've seen that. Women were put on estrogen and they had these surges of estrogen on top of it, and their estrogen is off the charts in the labs. And they come to my practice and they feel terrible because they were put on a monotherapy of estrogen, which is already ghetto medicine. But not only that, but they're not really in menopause yet. They still have estrogen happening. This is not the time to give them estrogen. Run the labs. Understand the woman in front of you. So lab work is key because you want to see where she is. There are women out here who are watching this right now, and I see you, and you know I see you because I just described you. This is how your doctor's supposed to talk to you. How I just spoke to you is how they're supposed to talk to you. This is it. They can use different words, whatever, but it should be the same material. Maybe little variances of it, fine. We all have our own style. But they should explain to you where you are. And then they should care about figuring it out. So how do we figure it out? How do I run my labs? When do I run labs? When do I understand what those labs mean? How's that? So a woman presents to my clinic with any symptoms associated with their endocrine system, their hormones specifically, and that could be the premenopausal state that I described where they're coming in, they're like, I emotionally feel not right. I have breast pain, my cycles are irregular, they're too far apart. These are my symptoms. I know what that means because I've spent all these years understanding this process, and we went to school to learn, but then after learning in school, we have to keep learning as doctors. We have to be curious and understanding people. So I know what labs to run. When you present to my clinic with these symptoms, say you're in that first phase we talked about, I'm going to run your progesterone on day 21 of your cycle. I'm also going to run your estrogen. I'm going to run FSH and LH. That's your follicle stimulating hormone and luteinizing hormone that comes from your pituitary. That's my understanding of what your ovarian reserve is. When I go at from that perspective and understanding you that way, I get a grasp. And that's just, those are my most base labs. That's not even going in depth. That's me grasping you as a whole human being. There's more labs I would run in some of these cases. Sometimes I will do serum serotonin. Sometimes I will run certain genetic markers to see if they have a genetic predisposition to not methylating, which would cause them to have lower levels of monoamines, which would be your serotonin, contributing to the problem. I want to be clever. Always be clever with your patients. Use all of your mind. So when you present to clinic in that first part, I run those labs. What happens if you're having these estrogen surges? What labs do I do then? Same. Just estrogen, progesterone. And when I say estrogen, estradiol, please know that. I run estradiol. I run progesterone. I run FSH-LH. I run the base labs to understand where you are within that cycle. There's a few others as I need to maybe, but these are the core ones. This is the core stuff. Do you see how this isn't difficult, this part? This part's pretty easy. It's interpreting it that gets a little tricky, but this is not like I'm running these weird combination of labs and having to do math. Any of you ever go to a nephrologist? That's math with labs, man. I have nothing but love and respect for nephrology, man. Those guys do a lot more math. And cardiology too. I'm not knocking cardiology, but nephrology, dude, they do dark math. They figure things out. So this lab work I'm doing here, I'm just looking for the rhythm and seeing where you are in there so that I can treat it appropriately. Why? Why do I do this? You are in a place in your lives where you go to your doctors now, and if you're in that mid-30s, late 30s, even early 40s, and you're having these symptoms of neurotransmitter synthesis, the problems with that, they're not going to sit here and say, let's look at your progesterone. They're going to say, here's your SSRI. And you don't have an SSRI deficiency, do you? No. But even if you did, they run the lab to verify that's what. There's no, see, this is science. And how many of you have been put on SSRIs where the doctor didn't really do a good history on why you need this and what your depression truly is? They didn't try to find a physical component. They just said, I'll just give this, get you out the door. You're good. No labs. It's cheaper, much faster for a doctor to just prescribe off the cuff, have you out the door. And if you come back or I have to do more, I'll change the prescription then. But they still don't try to figure it out. That takes too long, it seems. So why these labs are important is because giving you just an SSRI doesn't truly treat the problem. What if you're coming to my clinic and you're having the premenopausal state? And as I mentioned, I give you estrogen, too much estrogen. I didn't know what I was doing. I made it worse. So running labs is a critical component of care when it comes to this. And it's important your physician understands that. What lab values do we look for? It's a little bit on the trickier side, and we've done episodes on this before, and it always brings up some feedback on there because people are like, well, be more specific here and here. I will do my best, but please know, part of practicing medicine is an art. The woman in front of you is different from the woman that's going to be in front of you in a few hours. This woman, this one. You're all so unique. So when I find a balance of the woman, it's what's in the literature, it's what's in the text, so to speak, but it's also what's in the woman in front of me. So some women, their optimal is here, and that's the normal range. Say this normal range. They're here. Another woman's here. They're both very different human beings. Very rarely does it have to be here. Very rarely does it have to be here. But generally it's in here. So a lot of this, I always get nervous about giving you too many lab values and being, this is the best number for this, because there's no such thing as a best number. There's a range and there's a safe part, and then there's the woman here in front of me. So let's talk about that. In the literature, the standard reference range for estradiol in a woman luteal phase for premenopause or perimenopause, moving in that direction, the range is in here, standard. It's, picograms per milliliter for 43.8 to 211.0. That's the standard reference range. Optimal is in there too, but the key is that you need to see the estrogen and the progesterone as a balance. As you move through premenopause to menopause, as you want to go through that window, you're going to have this balance of estrogen and progesterone. And your body's going to lean more and more and more towards having more estrogen initially and having less and less progesterone because you have diminished returns on your progesterone. You're not going to ovulate every cycle, so progesterone is going to be going down every cycle. So you're going to see these moving down and progesterone moving down, estrogen moving up. And In the final stages of estrogen, of menopause, you see estrogen having these big spikes, big jumps, and then gone. And that's it. So when I run those labs on estradiol, I know the range where it should be. But in that first section of menopause, you're going to come in your estradiol, if your estradiol, say, is at 100, which is about approximately in the middle of that range. Okay, so it's 100 estradiol luteal phase. I then want to look at your progesterone through the same lens. The range of progesterone, sadly, is really terrible in the books, but it's 0 to 24. Let me say, no woman should be 0 luteal phase progesterone. If you're cycling, you're 0 luteal phase progesterone, you feel terrible because you need progesterone. You need it for brain chemistry, for mood, for wellness. Your uterus needs it. Breast tissue needs it. Every part of you associated with fertility needs progesterone. So it should never be 0. Okay. So say your estrogen is at 100 at luteal phase, picograms per milliliter. We want to see what your progesterone. And again, progesterone in nanograms per deciliter, nanograms per milliliter should be between 1.8. It's not 0. 1.8 to 23.9. And for me, it's about 25 to 23. That's where I hit it. If you're at the 100 for estrogen, I want your progesterone closer to 20. You know what I mean? It could be 15. I'm fine with that. It's in the range. It doesn't have to be the top end of the range. If progesterone is the 50th percentile, I'm fine with progesterone at the 50th percentile. Okay? Now, if the woman's estrogen is at 150, 200, I really need that progesterone closer to 23. So as a woman navigates from her 30s through her 40s, I'm always going to watch the progesterone and keep it in that upper end of the range. That's how I'm managing, or at least monitoring, diagnosing, etc. That's the labs. That's how we're running them. When she's hitting that second window where the estrogen is doing supraphysiologic, she'll hit like 900, as I mentioned before, 800. Sometimes that's just a one-off. And we're going to make sure that progesterone is staying at the highest end of the range. I may have to employ testosterone because testosterone is an anti-estrogen agent as well that could be very helpful in those situations. Very rarely do I have to use something to slow down estrogen manufacture in the body, like a aromatase inhibitor. Very rarely, but it happens to happen. But that's the lab we do then as well. And if that's what I see, that's how I treat. And that'll be in that other window there in the mid-40s where you see those spikes of estrogen. The final one, we're going to see that estrogen and that progesterone diminished all the way down, as I mentioned earlier, down to 0. And it's important to recognize that because if they hit 0, sometimes it hits 0 because you tested it and it's just that was what the month was. This is where I'm going to tease back in the need for FSH and LH. The thing about those two, they're highly flexible based on lifestyle and wellness. I've seen women in their early 40s push the FSH, LH towards menopause, and then after, not hormone replacement therapy, because hormone replacement therapy will bring those two down, by the way, and bring them into the normal range. So you can't say, oh, I reversed her menopause because I cured it, and now they can have a baby. That's not how this works. That's not how I'm describing this. You can change someone's diet and lifestyle so well that those hormones come back into a better range. And that's been published in the literature, and I've seen that. Even like a gluten-free diet has been profound for me for FSH-LH. So please know there are other factors of FSH-LH that I always keep in the back of my mind when I'm doing this with these women. So as a woman comes into clinic and she's in that very final window there in the late 40s, early 50s, and her estrogen and progesterone hit 0, if I see her FSH and LH elevated above 60, say, 30 is borderline for me. I know a lot of people say that is menopause, but 30, I've seen the ovaries come back from and have a few more cycles. So just be aware of that. But if I hit 0 and the FSH, LH are really high, I know this is the time to consider initiating estrogen therapy. Because the problem is if I initiate estrogen therapy, as I mentioned before, I want to keep reiterating, if I give them estrogen therapy too soon, not good. Because I'm adding on to them the estrogen they already have, they're going to be making more of. And now I'm making estrogen dominance, I'm going to make their symptoms go back to what they were in their 40s again. I don't want that. Don't want that. So lab work is an essential part of this, and understanding you as a woman starts there and where you are in the cycle of it. And that helps us create the treatment protocol, which we're going to get into in the next episode. I hope this is helpful. We're going to get more into this in our next episode, and we're going to get more into treatment. And then hopefully we'll go from there into the next series. Again, thank you so much for tuning in, and I'll see you soon.